Hi, good evening, everyone. We welcome you to another edition of the Young Guns webinar, this time from the Rajasthan chapter. And if you look at the uh, faculty today, it's a mixed bag. The topics are of a mixed bag, and it's going to be very interesting. The discussions, particularly, are quite interesting. We take time to answer all your queries. And it's also the presentation with the discussion that is the most enchanting part of these webinars. So I would like to ask Dr. Sunil Mehta to take over the proceedings from here. And I wish everyone all the best for the presentations. Over to you, Sunil Mehta, sir.
Good evening. This time, Young Gun webinar is being hosted by Rajasthan chapter of Society of Fetal Medicine. Our participants are Dr. Ashish Chaudhary, who is a radiologist and fetal medicine specialist, Dr. Aparna Prakash, who is also a radiologist, fetal medicine specialist, and she has got a special interest in fetal MRI. Then we have got Dr. Apar, who is also a radiologist and fetal medicine specialist. We also have two other participants who are obstetrician fetal medicine specialists. One is Dr. Shruti Bidla and one is Dr. Avantika Sharma. So these are the very talented and comparatively younger participants from Rajasthan, and I'm sure you will like their presentations. Dr. Charu, please take over.
Yes, sir. Thank you, sir. So, on behalf of the Society of Fetal Medicine Rajasthan chapter, I welcome you all. And without wasting any time, I would like to invite our first presenter, Major Dr. Ashish Chaudhary. He will be speaking on the topic NT scan, the gateway to fetal medicine. Over to you, Dr. Ashish.
Ashish, I think you're muted. There we are. Yeah.
Yes, sir. Now, sir. Sorry, sir.
Yeah.
Yes.
Yeah.
Yes, sir. Thank you very much. First and foremost, thank you very much. I'd like to thank Dr. Ashok Khurana, sir, Dr. Mohit, sir, Dr. Alok, sir, Dr. Sunil Mehta, sir, Charu, ma'am, for inviting us and giving us this opportunity to speak at such a prestigious forum. Sir, my slides are moving.
We're on your introductory slide at the moment.
Okay. Yeah, sir.
Okay.
And I'd like to thank my mentor and guru, Dr. Adinarayan Makham, sir, without whom I would have not been at this stage and without whom I would have not been able to do what little bit I am able to do in my field of fetal medicine and also in my life. So, without undue wasting time, let us go to the NT scan, the gateway to fetal medicine. This is how we have to take a nuchal translucency NT scan. NT scan does not mean just taking a nasal bone or a nuchal translucency. It's much more than that. As we are all members of SFM, we all know how to take this NT scan. I'll not go undwell in this one. Let us go dive into some of the cases which is there. Here at a 13 weeks fetus which has been there, which is visible, here we can see the nasal bone very well visible, the nuchal translucency all good, but there was some other abnormality. What I found was some defect which is in the palate. When I went to the another section, what I found was a unilateral cleft lip and a palate which was been there. Another section of the same to confirm my finding. Here we can clearly see there's a unilateral cleft lip and palate which has been there. On 3D rendered image, the baby was a little bit shy, but eventually it was able to show its face, and there we can see a unilateral cleft lip and palate as diagnosed as early during the 13 weeks of scan. Another case, this is a case of a median cleft lip and palate which was been diagnosed along with other findings. This is the autopsy feature confirming a finding of a median cleft lip and palate. This is the cleft lip and this is the median cleft palate which has been there. Now, this fetus, the spine looks on a cursory, casual look, it looks normal. But when you see finely and close enough, then you can find a hemivertebrae which has been there. Here, you can see clearly the hemivertebrae. Now, moving on to the another case. This case, the nasal bone appears normal. The nuchal transversus appears normal. But what we found here, the IT, the fourth ventricle was a little dilated. We suspected this as a case of a Dandy Walker malformation. We called that patient at an anomaly scan and confirmed our finding of a Dandy Walker malformation. This is the hypoplastic vermis with the upturned vermis with the dilated posterior fossa. This is the 3D rendered image of the same. This is another case where we can see the occipital encephalocystocele which is present. There was a postaxial polydactyly in the upper limb which associated. There was also a bilateral CTV with postaxial polydactyly in this fetus. There were enlarged bilateral kidneys with multiple cysts present within them. And there was also a single nostril with a median cleft lip diagnosed as early during the anti-scan. This is another case, a companion case, a different fetus showing a encephalocele which has been there. This is the abortus image showing the same, confirming a finding of a occipital encephalocele. The limbs were all good, the kidneys were good. We ruled out the Meckel-Gerber in that case. This is a case of a alobar holopresencephaly. Alobar holopresencephaly should be diagnosed at around anti-scan, and if you're missing, then something we are not seeing it carefully. I was not able to see any orbits, bilateral orbits, but I was able to see a cyclopia which was been there. There was aerania which was associated. This is the 3D rendered image showing the aerania, the cyclopia, and a low set ears which was been there. Unfortunately, this fetus was not available for us autopsy or for a genetic testing. In this fetus, around 12 weeks to 13 weeks, what we can find is a stomach bubble which has been herniated into the thorax. This is the case of a congenital diaphragmatic hernia, left-sided, diagnosed at anti-scan. The CDH at anti-scan carries a relatively poor prognosis. 12 weeks, the anti-scan is an excellent view time to see all your limbs. This is the case of a postaxial polydactyly at 12 weeks. Is it only just at 12 weeks? We can see much earlier. This case was suspected at around 8 to 9 weeks of the gestational age and confirmed at around anti-scan, a postaxial polydactyly. This is another case of a twin pregnancy where we can see a single live fetus which was being completely normal, and associated with that was a complete hydatiform mole. This could be a complete hydatiform mole, partial hydatiform mole, or some placental mesenchymal dysplasia. We have got a case series of around 5 cases. This fetus was able to go to a term. There is definitely other complication, but that is a discussion of another presentation. Heart. What we need to do at the anti-scan, we need to see the 4-chamber view, the tick sign which has been there, but we can see much more in this. We can see even the pulmonary veins which have been there at as early as during the anti-scan. Some of the features which have been there. Here we can see a case of a transposition of great arteries diagnosed at anti-scan. This is a case of a right aortic arch with the left ductus arteriosus. This is a case of a double aortic arch diagnosed at anti-scan. And this is a case of a aberrant right subclavian artery diagnosed at anti-scan. Moving further on to some of the cases. This was a case where there was a subcutaneous edema which was being noted. There was a AVSD which was associated. There was also a double aortic arch. But what was peculiar about this, that the aorta was narrow because of the asymmetrical AVSD which was been there. Along with that, this is the same 3D rendered image of a double aortic arch with the narrow aorta which has been right-sided. Another case of a AVSD with EIF in left ventricle. Along with that, there was also a subcutaneous edema and a small omphalocele which was been there. There was a CTV which was been associated with this one. Another case at anti-scan where we can see a heart which has been there. The left ventricle is small, contracting. The interventricular septum is echogenic. What we suspected in this case was a critical aortic stenosis leading to the hypoplastic left heart syndrome. Here we can clearly see the aorta being narrow in size, and there is a reversal of flow in the aorta. as early as during the 13 weeks, 4 days. Here we can clearly see the 3D-rendered image, the echogenic interventricular septum. Another case of a ABSD, but once you find one case, you need to see there was also a right-sided aortic arch in this fetus. There was also one more thing. There was a ductus venosus systemic shunt. DV was present, but it was draining not into the infradiaphragmatic portion of the IVC, but little scoudily in this one. We suspected this case. We called this patient for the 16 week. The patient went elsewhere and was diagnosed as a hypoplastic left heart syndrome, where we can clearly see this is a case of ABSD with the right aortic arch and a DVS. But fortunately, genetic testing was being done, and there was a loss involving the chromosome 22. This is a case of a tetralogy of Fallot, where we can clearly see there is an overriding of the aorta which has been there. This is the overriding of the aorta. This is another three vessel trachea view, where we can clearly see the overriding of the aorta. Now, some of the cases we can see, this is the 13 weeks, 3 days case, which is there because of the paucity of the time. I will not go in. This is, here we can see clearly the stomach is on the right side, the heart is on the left side. This is a situs ambiguous which was been there. Associated with this situs ambiguous was the ABSD which was been there, and there was also a 2:1 heart block which was been associated. Once further dwelling on this case, what we found, there's a left heterotexy because we can see the left atrial appendages, the finger-like atrial appendages. What proof do we have in this one? We did an autopsy for the same patient, and here we can clearly see the left-sided atrial appendages, finger-like atrial appendages, which we diagnosed at NT scan and confirmed on our at autopsy. There was an ABSD, this one. Along with that, there was the aorta was larger in size. There was overriding. We suspected it as a case of a double outlet right ventricle with pulmonary incident. This is the same, the large anterior aorta which has been there, small pulmonary which is there. Who determines our limit? We are our own barriers which is there. This case came into us at 13 weeks, 5 days. What we found is a dilated bowel loop which has been there. And what we suspected in this case was a cloacal malformation along with an anal atresia at 13 weeks, 0 days. We confirmed our finding on autopsy. Here we can see a smooth perineum. One time is always a luck. This is the cloacal malforma which has been formed. The second time is your consistency. This is another 13 weeks, 4 days. This is basically a politician family patient who had come right from the quota to us. And what we found is the dilated bowel loops which was been there. What we suspected in this case is anal atresia. There was also a finding. This is just to bring about, this is anatomy of the anal canal. We can see anus, anal canal and anal opening at the anomaly scan. The same can be replicated at the NT scan which has been there. And this fetus also had a single kidney which was been there. And our findings of anal atresia was confirmed on autopsy. So what I want to make it into retreat is NT scan is just not that nuchal translucency and everything. We have to see it's just like an early anomaly scan, and we need to do justice to that fetus whosoever has come to us. Thank you very much.
Thank you, Dr. Ashish, for this excellent presentation. And the way you have mentioned the autopsy images, you have captured those images. It's really fantastic. So now we move on to our next presentation. When too much right is wrong, a case series of right atrial isomerism. And for this presentation, I invite Dr. Aparna Prakash to kindly share the screen and take us through the cases.
Thank you so much, ma'am. Is my screen visible, ma'am?
Yes, yes.
Okay. Thank you so much, everyone. Good evening, everyone. So today, I'll be talking about right atrial isomerism when too much right is wrong. So let's just start at the beginning. What is situs? Situs is the arrangement of organs across the left-right axis of the body. So situs solitus is what we normally see, the liver mainly on the right side, the stomach mainly on the left side, the right atrium with its broad-based appendage and IVC and SVC on the right side, and the trilobed lung with the eparterial bronchus on the right side. Situs inversus is just the mirror image of this, whereas situs ambiguous is when this arrangement does not match either solitus or inversus. Now, more and more, as fetal medicine specialists, since we don't have all the information available to us at the time of the pregnancy, we can use the term ambiguous, but now more and more the pediatric cardiologists and the pediatric cardiothoracic surgeons want to move towards only calling it either a left atrial isomerism or a right atrial isomerism, because all of these cases, when you look at the atrial morphology, can be classified into these two. So let's talk about right atrial isomerism in particular. And I really want to focus here on the appendages, because most of the times we can recognize the appendages on the fetal echo. And if we recognize those appendages, we also know what are the abnormalities to look for. So the right atrial appendages are broad-based, pyramidal shaped, and most importantly, they have a broad connection to the atrium, whereas the left atrial appendages have a narrow sickle-shaped and a narrow attachment to the left atrium. The other thing that we can find in the right atrial isomerism is the trilobe lung with the epiarterial bronchus on both sides. And the position of the liver, stomach, and other viscera can be variable and so cannot be relied upon to make a diagnosis of right atrial isomerism. Let's just take a closer look at the atrial morphology. So this is a diagrammatic representation of the atrial morphology. So this is situs solitus. You have the broad-based right atrial appendage, also called the inverted India map appearance with the pyramidal shape. And most importantly, we define the atrial morphology by the presence of the pectinate muscles, which in the right atrium cross the infundibulum and reach up till the crista terminalis. Whereas in the left atrium, which is sickle-shaped and narrow-necked, the pectinate muscles are limited to the atrium and do not cross the infundibulum. So this is a normal case, and I just wanted to demonstrate the right atrial appendage morphology. Over here, we can see this is the broad-based right atrium, and this is the narrow left atrial appendage over here. So you can see this is sickle-shaped and quite narrow at the neck. So on fetal echo, we cannot always see the right atrial morphology, or it may be difficult to see because of the position of the fetus. And it is more reliably diagnosed on fetal echo by veno-atrial relationships and atrial morphology if possible. So what is always present in right atrial isomerism? It is isomeric symmetric bilateral right atrial appendages. A TA-PVC is always present because there is no morphological left atrium. The coronary sinuses are always, sinus is always absent. And there is always a juxtaposition of the IVC and aorta, which may be on the right or on the left. Commonly seen but variable is the presence of AVST, a single ventricular morphology, which is why it has right atrial isomerism has a poorer prognosis as compared to left atrial isomerism. Double outlet right ventricle can be commonly be present. Corrected TGA and pulmonary stenosis or atresia is also quite common. The extracardiac features, we all of us know them. The important thing is that we cannot rely on these features to diagnose left or right atrial isomerism. And how to differentiate right atrial isomerism from left atrial isomerism. I've already discussed right atrial features. In the left atrial isomerism, interrupted IVC will be present, often with azygous continuation, which gives us the double barrel sign. The atrial appendages, as we have already discussed, will both of them will be sickle-shaped or finger-like. The SVC will be left-sided, and of course, the complete heart block, especially if it's seen in the first trimester, can be diagnostic of left atrial isomerism. This is a simple diagrammatic representation I've taken from Dr. Chauvet's book, in which we can see the situs solitus, in which we can, in a single image, we can guess that it could be right atrial, left atrial isomerism, or situs inversus, depending on the presence of the vessels in the abdomen. So let's start with the cases. This was a primary gravid at 30 weeks of gestation. She was suspected to have ASD with pulmonary atresia on anomaly scan and was referred for fetal echo. So in the abdomen, so the fetus was in a cephalic position and the fetal left was on maternal right. We can see this midline liver with the midline gallbladder. The juxtaposed aorta and IVC on the left side. And actually, the stomach was not seen in the abdomen, but was present in the retrocardiac location as a hiatal hernia, which can be seen over here. In the cardiac findings, the apex was seen on the right side with a large balanced AVST. These are the bilateral right atrial appendages with pyramidal shape and a broad base. And no coronary sinuses could be identified. This is the Doppler loop of the same. We can see a large balanced AVST with the broad-based atrial appendages. Moving on to the vascular findings, there was the presence. So I think this is hung. So I think I'll have to stop share.
Okay, you can stop share and reshare.
Yes, sir. Yes, sir.
Can you go to the next slide of Dr. Pannu?
Yes, I'll just check. No, sir, this is hung.
Okay.
Is it a problem with my connections? Because everything else is working fine.
The vagaries of Zoom connections. All right. So perhaps
I'll
we can
just share
try.
again, sir.
Yes. I
I'm
think
so sorry.
you
Yes, sir.
can reboot your system, and meanwhile, Dr. Charu, can we move ahead? Can we have
Yes.
another presenter?
Yes, sir.
And then we can call Dr. Aparna back again. She can
Yes,
start
sir.
wherever she's left from.
So our next presentation is again some congenital heart defects which are rare but real. So I invite Dr. Avantika Sharma. She is from Savai Madhopur and she'll be speaking on this topic, the unusual congenital heart defects. Dr. Avantika? Yeah.
Yes, so we'll start now. Good evening, everybody. First, I would like to thank all the mentors, Dr. Ashok Khurana sir, Alok sir, Mohit sir, Sunil Mehta sir, and Charu ma'am for giving us this platform. So I'll be presenting some unusual congenital heart defects which are rare but real, and more importantly, they are detectable. So according to the ISOG, congenital heart disease have prevalence of 8.2 per thousand live birth, and it is the leading cause of infant morbidity and mortality. While many defects are routinely detected, rare anomalies often escape diagnosis, not because they are invisible, but because they are not actively looked for. Rare lesions are underdiagnosed due to reliance on the four-chamber view alone. These rare defects require careful assessment of outflow tracts and the three-vessel trachea view, which is where the diagnosis often lies. So moving on to my first case, which is a gravida 2 para 126-year-old woman referred to us for anomaly scan at 20 weeks of 3 days for oligohydramnios. There was no other significant history. So on systematic segmental analysis of the fetal heart, we found that the situs was normal. But in the four-chamber view, we could appreciate there was cardiomegaly, pericardial effusion, ventricular wall thickening, slight ventricular asymmetry with the left heart is slightly smaller than the right, inlet ventricular VSD, and poor myocardial contractility. These are again the four-chamber finding. We can appreciate normal cardiac axis, pericardial effusion, inlet ventricular VSD, and the asymmetry of the ventricle. Moving on to the next LVOT view, on tracing the ascending aorta, it appears to be tracing straight towards the neck, and there was a membranous VSD noted in this view. Then putting on the color, we found that this straight coursing aorta was dividing into two branches in the neck, most likely the brachiocephalic and the left common carotid arteries. The right ventricular outlet tract was normal. But in the three vessel trachea view, which was the key to the diagnosis for us in this case, we found that there was lack of continuity of the aortic arch, and there was at this bookmark we can appreciate that the trachea is in close contact with the pulmonary artery because there is no medially located aortic arch. Simultaneously, we could appreciate a aortic pulmonary window also in this section. In the longitudinal view of the aortic arch, we could not appreciate the normal candy-can curvature, which has to be there, as we can see in this image. Instead, the aorta was coursing straight towards the fetal neck. Associated extracardiac anomalies was bilateral renal agenesis, right clubfoot deformity, and there was anhydramnios. Some of the fetal cardiac view we cannot see appropriately because of presence of anhydramnios. Seeing all these features, genetic testing was offered, but patient did not agree and terminated the pregnancy, so we could not follow the pregnancy further than this. So our final diagnosis was interrupted aortic arch, most probably type B. Along with there was some cardiomyopathy, aorticopulmonary window, bilateral renal agenesis, right clubfoot deformity, and anhydramnios. So what is interrupted aortic arch? It is a rare congenital heart disease. There is discontinuity between the ascending and descending aorta due to faulty embryological development of the aortic arch in the 5th to 7th week of intrauterine life. Where the continuity happens, there are three types based on that. And in our types, we found that it was kind of type B interrupted aortic arch, where the discontinuity happened after the origin of the left common carotid. These are the ultrasound pictures of I've taken from Rabi Chow sir's book. We suspect IA type B when we have an ventricular septal defect in the four-chamber view. Then again in the LVOT view, moving on to three-vessel trachea view, we found that there is discontinuity of the aortic arch, and in the longitudinal arch view, there is straight coursing aorta in the fetal neck. Associated anomaly that can be seen with these cases could be AVSD, single ventricle, DORV, and extracardiac malformation will be Digeorge syndrome, which is associated in 50% cases of the interrupted aortic arch type B. Differentiating between the three subtypes is sometimes very difficult, and interrupted aortic arch needs to be differentiated from aortic coarctation and tubular hypoplasia, but here the ventricular size discrepancy is prominent and aortic arch is maintaining its normal candy-can curvature. Sometimes the straight coursing aorta can be confused for superior vena cava, but the origin of the aorta from the middle of the heart and the color Doppler showing forward flow from the heart to the neck vessels helps in this differentiation. What is the prognosis? It is a duct-dependent lesion, so the prenatal diagnosis must result in delivery of the neonate at a tertiary care center with pediatric cardiology services. Prostaglandin infusion immediately after delivery should be given to maintain the ductal patency. Surgical repair must be done in the first 5 to 7 days of life. Success rate is approximately 90% when it is repaired in the newborn life, and for which the antenatal diagnosis is the key factor. The main prognostic marker is association with Digeorge syndrome. So my case 2 is Gravida 1. 22-year-old referred to us for anomaly scan at 27 weeks. They somehow missed their targeted scan at 18 to 22 weeks. So on segmental analysis of the fetal heart, we found that the situs was normal. In the four-chamber view in the 2D, first look fairly normal, but on putting the color, what we appreciated there is a little less amount of blood flow in the right side of the heart, and there is an apical muscular VSD. Doing the biometry, we found that there is a little ventricular asymmetry with right side of the heart being a little smaller than the left one. Again, coming to the 2D four-chamber view, we found that there is a membrane extending in the right atrium, dividing it into the two parts, the medial part and the lateral part. Moving on to the other views, the LVOT views and the RVOT views look fairly normal. But in the three-vessel trachea view, we again appreciated that the pulmonary artery is a little smaller than the aorta. And in the bicaval view, we found that there is a membrane, thick echogenic membrane located at the junction of the IVC and the right atrium. On putting the spectral Doppler in the tricuspid valve area, we found that there is some noisy pattern noted in this spectral Doppler and reduced amount of blood flow across the valve. So my probable diagnosis in this case was co-triatrium dexter, a heart with 3 atria. We also kept 2 other diagnoses in the differential diagnosis. One is the prominent eustachian wall and other is Chiari networks. These 2 can also present a membranous structure in the right atrium, but they both are non-obstructive and does not cause reduced blood flow in the right side of the heart. So for probable diagnosis, we kept the core triatrium dexter as our first diagnosis. The extracardiac anomaly found in this case was single umbilical artery. So genetic testing was offered, but patient refused. They continued the pregnancy, but unfortunately, we could not trace the pregnancy further. So what is co-triatrium? It is a heart with 3 atria. It is a very rare congenital anomaly with 0.1 to 0.4% of all congenital anomaly. There is presence of a membrane in either the right and the left atria. When it is in the left atria, it is called as sinister variety. And when it is in the right atria, it is called the dexter variety. The dexter variety is rarest and it is because of the persistence of the embryological sinus venosus valve. So when do we suspect co-triatrium? This is the case we have taken from Rabi Chow's book. They saw this baby at fetus at 23 weeks and they saw a small right ventricle, less flow in the right ventricle and a smaller pulmonary artery along with some noisy pattern in the tricuspid valve spectral Doppler, but they could not find anything other than that to particularly diagnose what kind of anomaly is there. So they followed the case again at 31 weeks and then they could appreciate there is a membrane in the right atrium and during diastole, it bulges into the right ventricle. Though in our case, we could not see a bulging membrane, but co-triatrium dexter is a progressive anomaly, and as the pregnancy advances, the severity of the obstruction increases. Till now, only 3 case reports have been reported about the antenatal diagnosis of the co-triatrium. The prenatal monitoring is required for severity of obstruction and size of the right ventricle. Postnatal treatment, if membrane is not restrictive and the baby is asymptomatic, only observation is needed. But if the infant is symptomatic and there is significant obstruction, surgical excision of the membrane is the treatment of choice. The outcome is mostly good even if the surgical excision is required only when it is done in the immediate neonatal period. Moving on to case 3, it is gravidae to abortion 1 referred at 23 weeks 4 days for anomaly scan with a reporting said that there is some congenital heart disease. So on segmental sequential analysis, we found that the situs was normal, but there was extreme left axis deviation. The 4-chamber view looked fairly normal, but moving on to the left ventricular outflow tract view, we appreciated that there is a malaligned VSD with the overriding aorta, but conversely to the classical tetralogy of Fallot, the aortic root was not dilated, and on putting spectral Doppler across the aortic valve, the high velocity jets were noted across the aortic valve. Moving on to the right ventricular outflow tract, we found that there is aneurysmal dilatation of the main and the branch pulmonary arteries. This is the 3D rendering of the same, which is the typical sonographic feature of absent pulmonary valve syndrome. The main pathology here is the absent ductus arteriosus and the pulmonary valve we could not appreciate. Putting on color in the RVOT view, we found that there is bidirectional flow across the pulmonary valve annulus with increased realizing suggestive of high velocities, blood filling the main and branch pulmonary arteries in the systole and regurgitating back into the right ventricular during diastole. Similarly, in the spectral Doppler at the pulmonary valve annulus, we found that there is typical to and fro flow across the pulmonary valve with high velocities, which is a sign of both stenosis and severe insufficiency. We also suspected some association of Dijot syndrome in this, as we observed here that the pulmonary artery is located just beneath the sternum and we could not appreciate the thymus in this case. Genetic testing was offered, but the pregnancy was terminated without it. My final diagnosis here is tetralogy of Fallot absent pulmonary valve syndrome. It is a very rare congenital heart disease and it includes 3 to 6% cases of tetralogy of Fallot. The pathology is the absence of ductus arteriosus, because of which there is increased blood flow across the pulmonary artery, include the lung, resulting in dilatation of the pulmonary artery and poor lung development. These are the ultrasound findings through which we can diagnose that there is overriding aorta and malaligned VSD. There is dilated main and branch pulmonary arteries and bidirectional flow in the color Doppler as well as in the high velocity jets in the spectral Doppler. Associated cardiac findings could be absence of ductus arteriosus, which is noted in 87% of the 87.5% cases, right-sided aortic arch. In extra cardiac problems, we can have chromosomal anomalies in 12% of the cases, and Dijot syndrome is 32% of the cases. We also have to explain to the parents that apart from cardiac anomaly, there will be pulmonary pathology, because more the dilated the pulmonary artery, there will be more chances of bronchomalacia and respiratory distress at the time of birth, and simultaneously there is poor lung development due to abnormal division of the bronchiole and pulmonary vasculature. To differentiate it from the classical TOF, here we can see that the aortic root is normal size, while in classical TOF it is dilated. Pulmonary artery here is markedly dilated with to and fro flow, while in classical TOF it is narrow and antegrade flow. Ductal arteriosus is absent in here, and in classical TOF it is antegrade or retrograde flow. Prognosis is poor in absent pulmonary valve syndrome, while it is fairly good in TOF. And absent pulmonary valve syndrome is mostly associated with Dijot syndrome, and TOF is mostly associated with aneuploidies. This is to differentiate it from the other causes of VSD blood overriding. But as we have seen, that pulmonary artery originating from the right ventricle and very large in size are clear enough to diagnose the absent pulmonary valve syndrome. Prenatally diagnosed APVS has a poor outcome. Only survival is 15 to 30%. The high mortality is because of cardiac failure and associated bronchomalacia. Poor prognostic signs are cardiomegaly and marked pulmonary dilatation. Prenatal counseling should take into account the progression of the lesion in utero. Nowadays, studies are coming up that the surgical repair is becoming promising. Prenatal monitoring is required to diagnose monitor the cardiomegaly and development of hydrops. Postnatal treatment is needed to reciprocate the bronchomalacia because of severe airway compression. Surgical intervention is the definitive treatment. So to conclude, not all critical CSDs are obvious. Some hide beyond the four-chamber view. Systematic segmental analysis changes outcome. Early diagnosis results in planned delivery plus surgical preparedness. So my take-home message is rare does not mean impossible. If we look carefully enough, rare defects stop being missed. What we do not actively look for, we do not diagnose. Thank you.
Thank you, Dr. Avantika, for the lovely cases. And now, should we move on for the trade partner video, or Dr. Avantika is ready?
Ma'am, I'm ready if we can share.
Okay. So you can share your screen, and
Right.
you can start from where you had left, and
Yes.
then we can have a trade partner video, right?
Is my screen visible, ma'am?
Yes, it's visible.
I'm so sorry for the technical glitch. Staying on course. So in the vascular findings, we saw the presence of a type 1 common arterial trunk. So these are the pulmonary arteries arising from the common tongue, and this is the aortic arch. There was also the presence of a TAPVC. So this is over here, you can see the common channel forming behind the heart, and then moving upwards and then moving superiorly to drain into the right brachiocephalic vein. This is the slow flow view of the same. So here we can beautifully see the common channel forming behind the heart and then moving superiorly over here to drain into the brachiocephalic vein. So this is the this is the vertical vein draining into the right brachiocephalic vein, and there was the presence of a left SVC. So these are the stick reconstructions. This is the common valve. And over here, I've tried to recreate the end-fast view of the common valve. The fetus was terminated. The patient did not opt for genetic evaluation. Moving on to the second case, this was a 25-year-old primigavida at 28 weeks of gestation, and she was diagnosed as HLHS elsewhere and was referred for a fetal echo. So the fetus was in a cephalic position, and the fetal left was on maternal right. In the abdomen, we could see the presence of a midline liver, the aorta, and the IVC. This is the gallbladder in the midline. The aorta and the IVC were juxtaposed on the left. And again, the stomach was seen. The stomach was not seen in the abdomen and was present as a hiatal hernia. In the cardiac findings, The apex was on the right side. Again, there was presence of a large unbalanced AVST. This is the smaller left ventricle that can be seen. Most likely the left ventricle that is seen over here. And again, on this image, we can demonstrate the beautifully the pyramidal shape, broad-based right atrial appendages on both sides. On color Doppler, again, we can see the large unbalanced AVST. In the vascular findings, there was presence of demalposed great arteries arising from the left-sided ventricle, which is probably the morphologic right ventricle. So these are the demalposed great arteries. There was also a tubular hypoplasia of the aortic arch, which can be seen on the oblique transverse view over here. And then on the sagittal view, this was the tubular hypoplasia of the aortic arch. There was also the presence of TAPVC. This is the common channel forming behind the heart and moving superiorly to drain into the right brachiocephalic vein. So this is the MB flow image in which I've tried to better demonstrate the venous findings. So over here, we have the common channel forming behind the heart, moving superiorly to drain into the right brachiocephalic vein. So this is the common channel moving over here, and it is moving upwards superiorly to drain into the left brachiocephalic vein. There was also, in this view, we can see all the findings. So we have both SVCs over here. We have the vertical vein draining to the right brachiocephalic vein over here. And then we have the tubular arch hypoplasia. Again, the patient did not opt for genetic testing, and the pregnancy was terminated. This case I recently saw just a few weeks back, and the patient is continuing with the pregnancy. And this patient had actually just come for a growth scan, and she did not give me any information of whether there was an anomaly present or not. So while I was scanning, these are the findings that I saw. In the abdomen, the baby was in a breech position, and the fetal right was on the maternal right. So we have the midline liver, and we have the midline liver. We saw the stomach on the left side, the stomach on the right side. This is the stomach on the right side. We could also appreciate the spleen. This is the spleen that was seen since the baby was a later gestation. We could also see the spleen again on the right side. And there was also, I could also appreciate the presence of altered SMA-SMV axis. So this is the SMA, and we can see that the SMA is moving on to the right side of the fetus. So there was also, most likely, there was presence of bowel malrotation as well. So in the cardiac findings, the apex was seen on the left side, and there was the presence of a partial AVST. As on color Doppler, we can appreciate two inflows. So there was a presence of a partial AVST. There was an associated VST that can be seen over here. And again, we can appreciate the broad-based right atrial appendages on both sides. There was an associated presence of a CCTGA with demalposition of the great arteries, and the presence of a pulmonary stenosis. So here we could also appreciate pulmonary stenosis in this case. There was the pulmonary veins were actually seen draining into the left-sided atrium. But again, it would be considered as TAPVC only, because in a right atrial isomerism, a morphological left atrium is not present. And there was also a presence of left SVC. This patient is still continuing with the pregnancy, and the history was that she was actually hoping that in this scan, everything will turn out to be normal. So actually, she had a proper fetal echo report in which all the findings had been described. So for the genetic workup, earlier it was advised that no genetic test needs to be done in this. But now with the advent of whole exome sequencing, up to 10 to 20% of cases can have genetic abnormalities, especially involving the ciliary genes. And in all cases, we should at least advise the patient to undergo whole exome sequencing and CMA. and especially in right atrial isomerism because it has a higher percentage of genetic abnormalities. So concluding my talk, if tomorrow you sit and start your work, and if you see stomach and cardiac apex on opposite sides, a complex cardiac defect, a heart block, or venous anomalies in the fetus, start suspecting right atrial isomerism. You can diagnose right atrial isomerism by looking at juxtaposed IVC and aorta, TAPVC, bilateral right atrial appendages, and absent coronary sinuses. You should report it by taking a systematic sequential approach. Not just the diagnosis of right atrial isomerism is important, but it is more important to give all the morphological and functional abnormalities that are present for better clinical decision making. You need to prognosticate this baby by telling whether whether the TAPVC is obstructed or not, or whether there's presence of pulmonary stenosis or atresia, because then the baby will need immediate neonatal management. And like we saw in my last case, I don't know if the patient was counseled or not, or the patient was still just hoping for a normal outcome, but the counseling of these cases is really important. We have to advise genetic analysis by CMA and West, as many of these cases can be autosomal recessive inheritance. We have to advise the patient to deliver in a higher center because the baby might need prostaglandin infusion for a ductal dependent system and an urgent TAPVC repair if the TAPVC is obstructed. Again, even with everything, the prognosis is poor, especially in cases of right atrial isomerism, because these patients are most likely going to need multiple staged operations. They can also have sepsis due to asplenia, and they may also need non-cardiac surgeries such as Lard's procedure for the bowel malrotation. Just concluding with this simple infographic from Dr. Chauvet's book. Thank you so much.
Thank you, Dr. Aparna, for this excellent presentation and perfect time to stretch your neck. So we'll come back after a short trade partner video. So don't leave. We'll be back with the two brilliant presentations. So welcome back. And I hope we all have stretched our necks and extremities. So moving on to our fourth presentation, when extremities speak first, the Arthrogryposis spectrum, and the presentation will be done by Dr. Shruti Birla. She is a fetal medicine specialist from Jaipur. Over to you, Dr. Shruti.
Thank you so much, ma'am. And firstly, thank you so much to our mentors for giving this beautiful opportunity to Rajasthan and to the young presenters. I would immediately start with my case for Arthrogryposis spectrum when extremities speak first. To begin with my case, she was a primi gravida, 25 years old, spontaneous conception, non-consanguineous marriage. She was referred to me for a routine anomaly scan at 22 weeks, and her first trimester screening wasn't done. And when I started the ultrasound, the extremities were of this kind, wherein I could see a bilateral CTEV, and upper limbs, it showed persistent clenched fist and flexed upper limbs. And also I could make out some mild subcutaneous edema over the trunk and the scalp. Stomach bubble was very small throughout, and it appeared like slight scoliotic spine as well. There was no fetal movement or change in limb positions despite spending almost my complete day for her evaluation. And provisionally, I gave her a diagnosis of distal arthrogryposis, and I offered an amniocentesis to know about the genetic etiology, but patient underwent termination without testing. The case went on further. The story reappeared to me after 6 months as case 1.1. Her next pregnancy at 14 weeks gestational age, the baby appeared with almost similar findings. There was bilateral CTV, again the same. You can see clenched fists and flexed hands. So again, I made the same diagnosis, again offered the same tests, and again the patient went termination, but this time we were able to undergo an exome of the abortus, and the report came out to be Arthrogryposis distal type 1C. which was an autosomal recessive condition. Kind of good part that it have a 25% of recurrence, as distal type arthrogryposis usually autosomal dominant with 50% of recurrence. So basically what arthrogryposis is, it is not a disease in itself, it is a description of symptoms which can result from various kind of underlying causes. The term arthrogryposis itself, it means curved or hooked joints. It's a condition which is characterized by first joint contractures, that is stiffed or fixed joints in more than two joints in more than one body area. There is limited range of movement in multiple joints, and there is muscle weakness around affected joints. The different causes includes conditions which limit the joint movements, possibly like neurological or muscular disorders, connective tissue abnormalities, limited space in uterus, or genetic conditions. So grossly we can divide the causes into intrinsic and extrinsic ones. The extrinsic ones causes includes infections like rubella or zika virus, teratogens like cocaine or even mifepristone, phenytoin, maternal myasthenia gravis, or reduced space in utero because of oligohydramnios can also cause it. And the intrinsic conditions may include chromosomal abnormalities like trisomy 18 or trisomy 8. There may be microdeletions, duplications, certain single gene disorders, congenital anomalies with which includes myopathies, neuropathies, or metabolic disorders. Commonly, the ultrasound findings which we see in these cases are club fit, clenched hands. There is polyhydramnios, but collapsed stomach. There may be skin edema. If we see these patients early, there may be association of increased NT. Brain and spine abnormalities could be noticed according to the etiology, because of which arthrogryposis is happening. Facial abnormalities and pulmonary hyperplasia or narrow thorax can be seen in certain types. So when we talk about types based on the underlying causes and pattern of involvement, arthrogryposis is grossly divided into four types. The first type is amyoplasia. So as the name suggests, there is the muscles are hypoplastic, they are not developed properly, there is marked muscle hypoplasia. It is the most common type, but it is a sporadic type, and it accounts for almost 40 to 50% of cases. There are severe joint contractures, limbs appear tubular, there's paucity of soft tissues, there's very you can very clearly demarcate it on ultrasound. But in these conditions, intelligence of the babies do not suffer. Usually it is because of vascular insults during the development of fetus. The second type is distal arthrogryposis, in which mainly the upper and lower limbs are affected, mainly hands and feet are affected. They are usually genetic and more commonly autosomal dominant. They are caused by mutations which affect muscle contractile proteins, and if we go for their subtypes, there is a big long list with lots of mixing of the features which appear on ultrasound. So for all these, we just need to go for a genetic diagnosis. The third type is the syndromic arthrogryposis, wherein joint contractures are associated with other system abnormalities like CNS malformations, maybe chromosomal disorders, metabolic or connective tissue disease like Larsen syndrome, trisomy 18, or Penna-Shakir syndrome. And the last one is neuromuscular arthrogryposis. They may be due to anterior horn cell disorders, peripheral neuropathies, congenital myopathies, or muscular dystrophies. So according to these, we will have various findings in our fetus. Now there is a lot of confusion which occurs, and there is intermixing of the terms fetal akinesia deformation sequence versus arthrogryposis multiplex congenita. So arthrogryposis is a non-progressive condition wherein we see the joint contractures, whereas fetal akinesia deformation sequence, it is a sequence. Due to fetal akinesia, there is a sequence which keeps on developing. If you talk about the nature, AMC, it is a clinical diagnosis. It's an umbrella term which we are using, whereas fetal akinesia deformation sequence they are pathophysiological sequence. If we talk about the features which we see clinically, there are in AMC joint contractures, they are present. In FADs, they are present in severe form. Facial anomalies usually are absent in arthrogryposis, which is very common, like micrognathia, etc. We can see very commonly in fetal akinesias. Pulmonary hyperplasia is again a common feature of fetal akinesia. If we talk about prognosis, the arthrogryposis fetus, they have survival, but fetal akinesia, they either will face an IUD, or otherwise very soon they'll die after birth. There is high perinatal mortality. limb contractures in arthrogryposis are symmetric in akinesia and this akinesia deformation sequence. Also, there is simple limb contractures and they are fixed. Bone mineralization usually normal in both conditions, and there may be variation in associated findings, like especially in fetal akinesia, we see pulmonary hypoplasia very common, which is the reason why it is quite lethal. Whereas in arthrogryposis, hip dislocations or scoliosis are more common. In prenatal USG, we see reduced movement in arthrogryposis, but almost absent movement in fetal akinesia. According to the type of arthrogryposis, we will be looking for the movements. If we talk about severity, arthrogryposis mild to moderate in severity, whereas it's quite severe in fetal akinesia. Systemic involvement in arthrogryposis is quite limited, whereas in fetal akinesia, there is multi-system involvement. Mainly in arthrogryposis, our diagnosis is based on the contractures, whereas in fetal akinesia, along with arthrogryposis, systemic anomalies are also involved. So and obviously, as we talked, there is high perinatal mortality in fetal akinesia, whereas arthrogryposis survival is there, and these fetus, if the contractures are not very severe, they can be managed postnatally. So the crux is all fetal akinesia deformation sequence, they show arthrogryposis, but not all arthrogryposis cases are fetal akinesia deformation sequence. So for arthrogryposis, the key prognostic factors are first thing, if the contractures are present at birth, but they do not get worse, because usually in arthrogryposis they are non-progressive in nature, so they can be improved through treatment. Intelligence in the most common type, amyoplasia type of arthrogryposis, intelligence is typically normal, so we do not see cognitive disorders or behavioral disorders in these babies. Therapeutic response will totally depend. If we start intensive physical and occupational therapy at a very early stage, a good response may come up. But the limitation and challenges we face is that even after a lot of improvements, still on a daily basis for day-to-day activities, these kids may face some limitations. And definitely, if the treatment has been postponed and surgical treatment is needed, and it is not successful, there is even a chance of losing the existing functionality in these kids. So my key message is, firstly, arthrogryposis, it has multiple underlying causes. We need to look for the cause to decide the management of the fetus. Not only it is important for this pregnancy, but for the upcoming pregnancies as well. Antenatal diagnosis is obviously possible, but not only in this way, but also we can classify it, and we can definitely rule out the genetic etiology, which is very important. A proper teen counseling should be arranged for the family to understand the prognosis, to understand the management strategy, so that even if the couple decides to continue the pregnancy, we can give the best quality life to the fetus, to the baby. And recurrence risk for next pregnancy has to be explained to all the patients according to the type of arthrogryposis we find. Thank you so much.
Well said, Dr. Shruti. Excellent worker. Now we move on to the last talk of this evening. Meeting at the midline, evaluation of midline facial defects. And I invite Dr. Apar Mathur for this presentation.
Good evening, everyone. I hope I'm audible, and this is my presentation. I'm really humbled to be a part of this elite forum, and thank you so much for giving me this opportunity. So I'll just start in with my presentation. So diving right into meeting at the midline, evaluation of the facial defects. Discussing the embryology a little. So we all know that these are the frontal nasal processes. These are the lateral nasal processes. This is the maxillary process, and they all meet in the midline somewhere around 8 weeks. And if that fails to happen, this is the plethora of cleft lip and cleft palate deformities. We are going to discuss each one of them in a little bit of a detail and see a case of each one of them. So now, just focus with this line diagram for a while. This red line, this is the upper lip. This is the alveolus. The palate fusion, the diamond part in the between, can you see the triangular part? This is the primary palate. The two lateral processes, these are the lateral secondary palates. This is where the soft palate is going to be. So now, as we can all see, the deformity in the upper lip on one side unilaterally, and it is extending into the alveolus. This is a unilateral cleft lip defect. Looking at the case of it, a 27-year-old primary gravida, non-consanguineous marriage, came at 20 weeks for the scan, anomaly scan routine. And there we can see a small defect in the lateral side in the upper lip. So that's unilateral cleft lip. The palate appeared to be normal in this case. This is the 3D rendering image, a very subtle cleft lip, and this is what the baby looked like in the end. Now, this is another variant of a cleft lip only, but this is not an actual cleft lip. A 32-year-old female non-consanguineous marriage came for an anomaly scan at 21 weeks. And here again that you can see a defect in the nasal bridge. However, the upper lip and the palate appears to be normal. So this is just an isolated alar cleft nasal alar cleft defect. This is not a cleft lip. This case is shared to me by Dr. Rohit. Thank you so much for the great images, Dr. Rohit. This is the reverse face flipped view. As we can see, the nasal alar defect. And this is how the baby looked like. You can see the lip is intact, but just a small nasal alar cleft. Okay, now coming to bilateral cleft lip, we can see the defect of the upper lip seen bilaterally extending into the alveolus. However, the palate still appears to be normal. This is one of my cases just from a few days back. 34-year-old female, G2P1A1L0, non-consanguineous, 19 weeks, came for the anomaly scan, and there in the upper lip, we can see the defect in the upper lip bilaterally. And however, the palate appeared to be normal. So this is bilateral cleft lip. Now the defect has extended from the upper lip to the alveolus, involving the palate here. Both the hard palate and the soft palate is involved. Coming for the case of it, 29-year-old female, G1P180L0, non-consanguineous marriage, 20 weeks, came for the anomaly scan, and here we can see the defect in the upper lip, and this time it is seen extending into the palate. This is the maxillary arch, and you can see the defect in the maxillary arch, and the defect is seen extending up into the palate. So the extent of the defect is actually well visualized on multiplanar imaging. So when we do the axial imaging, we see the defect, and then we can see that in the upper lip, and then we can see the defect seen extending into the palate. And this is the retronasal triangle on the coronal view. We can see, so the base of the triangle, as we all know, is formed by the primary palate, and the defect in the base of the triangle is a feature of cleft palate. Now cleft palate bilaterally. So as we can see, the defect is seen extending, involving the upper lip, the alveolus, reaching up to the palate and going deep down. However, as we can see, this triangular part of primary palate can still be seen, and this appears as the pre-maxilla in the image. So this is an NT scan of a twin gestation that we did, and there you can see this is the maxillary arch, and a defect, if you can see, very subtly seen bilaterally. And this is what a pre-maxillar protrusion looked like in bilateral cleft lip palate. So this is the mid-sag view. This is the nasal bone. This is the maxillary line, and we can see a breach in the maxillary line, and the primary palate, that is the pre-maxilla, is protruded anteriorly and causing a nasal protrusion. This is what it looks like in real time. Now the hidden deformities. So the nasal nostrils appear normal, lips normal, alveolar normal, only defect involving the palate, both the hard and the soft palate, or only the soft palate. I, in my practice, have never got a chance to see something like that, but during my fellowship days with Adi sir, that's what I saw. So normally, how do you identify only a cleft palate? So this is an appearance of a normal uvula. This is called the equal to sign of the uvula. This is what a uvula looks like on the coronal image. However, the absence of uvula is a feature of secondary palate defect, that is a hard palate or a soft palate defect. It is very difficult to visualize, but not impossible, as Adi sir says it. So now coming to a little bit of a theory, incidence, 1 in 700 pregnancies will have a midline facial defect. That means we all will see one of these cases at least once in every 3 months. More common in males than males. 25% is isolated cleft lip, 25% is isolated cleft palate, and 50% involves both. 75% unilateral, predominantly in the left, and 25% is bilateral. Associated abnormalities most commonly associated with trisomy 13 and 18 in approximately 1 to 2% cases. Unilateral cleft lip is rarely associated with abnormalities. However, there are chances that it also can be related to genetic abnormalities. Median cleft lip palate or bilateral cleft lip palate without any premaxillary protrusion is more likely to have associated with CNS abnormalities. I will show a case of that very shortly. If cardiac abnormalities are associated, consider 22q deletion. You can also have a Treacher-Collins syndrome, which has hypoplasia of the maxilla, clefts, and micrognathia. Golden Hair syndrome, which has facial macrosomia, ear defects, and clefts. Pierre-Robinson syndrome, which has micrognathias, clefts, and glossoptosis. So now how to come to the diagnosis of it? We have to do a 3-section analysis. And I'm pretty sure we are all doing good 3D images in our current scan, all good fetal medicine specialists here. We have to do a coronal view, an axial view, and a mid-sag view. So the best way to assess a cleft lip, you give a good 3D rendered imaging. Most likely if there is a defect, it's very easily visible due to 3D imaging these days. But what are the criteria for it on ultrasound? Subjective criteria are prenasal protuberance, as we just saw, or the maxillary arch gap. And objective criteria are prefrontal space distance, palatino-maxillary distance, and maxillonasion and mandible assessment. Such assessments are mostly required by the surgeons when they come to treat an isolated defect like this. So when we are diagnosing, in the sagittal image, we have to see this is the nasal bone. This will be the maxillary line, and this is the mandible. So if we have to draw a line tangential to these, so if there should be very little skin protruding anterior to this line. If that doesn't happen, if that is more, then we have to suspect a cleft palate or a cleft lip defect. When we are diagnosing in axial images, this is the maxillary arch. A defect in the maxillary arch is a feature of cleft palate. In the coronal image, this is the retronasal triangle formed by the nasal bones, the lateral processes, and the hard palate forming the base. So if there is any defect seen here, either in the midline or on the either side, this is a feature of cleft palate. So on good 3D images, a unilateral cleft lip can very easily be seen, as you can see in this image in 3D. Bilateral cleft lip very easily visible on this, and a midline defect, as we can see, beautifully visualized in the midline on 3D images. So on mid-sag image, we can still get a suspicion of a cleft lip. We get a good midline section. We try to see the nasal bone, the maxillary line, and the mandible. So a shortening of the maxillary line or the absence of maxillary line is a feature of cleft palate. Here again on mid-sag view, we have already discussed the protrusion of the premaxilla, and here in this case, you can see there is retrogranthia present, which is also a facial defect. Additional views that are going to help us to diagnose will be, as we just discussed, the coronal view, where we have to see the retronasal triangle, the nasal bones, the lateral processes, and the base of the triangle is formed by the hard palate, and here the defect, and we can see a cleft palate. And on the axial view, there is a defect in the alveolar ridge in the maxillary arch, and that's how you can suspect a cleft lip, cleft palate. You have to look for the asymmetry of the nostrils. If there when we do the coronal section, and you can see the asymmetry in the nostrils, and there it is on the 3D rendered imaging, we can see this is a feature of a cleft lip. Again, in the mid-sag section, you can diagnose it with either a hypoplastic maxillary line or an aplastic maxillary line, absence of the maxillary line. So this is one of a very interesting cases that came to me. The patient unfortunately came to us at 32 weeks just for a normal growth scan. And there we saw on the 3D rendered imaging of the face a very, very evident midline facial defect. I was unable to get a good maxillary line in the image, but all I could see was the protrusion of the nasal prominence. The patient also had bilaterally enlarged kidneys, renomegaly. These were more than 5 centimeters at 32 weeks, which is renomegaly. And the patient also had a holoprosencephaly. So radiologically, we diagnosed this case as Patau syndrome. But as always happens in fetal medicine, we couldn't prove it because the patient was lost to follow-up after I diagnosed it. Now, prognosis. Prognosis depends upon the types and the associated abnormalities. If there are isolated abnormalities, they generally have a very good prognosis. Surgical repairs can be offered by between 3 to 6 months of age. And we should always look for dental and hearing and olfactory abnormalities if you had such a case. You should also focus on speech and cognitive development abnormalities in cases like this. Recurrence rate, if there is in isolated cases, if there is one sibling informed, there are 5% chances. However, if there are two siblings involved, previously affected, it doubles to 10%. Syndromic associations are almost seen in all of the cases. So my take-home messages are a detailed ultrasound in all three planes will help us diagnose cleft lip and cleft palate almost in 100% of the times. We should also do karyotyping in such a case, also advised because almost they're all associated with some genetic abnormalities or the other. You should always also advise microarray for some very small micro deletions. These are my references. In the end, as I always thank Dr. Adi sir for whatever I know in fetal medicine is because of Adi sir. Thank you so much, sir. And a special thanks to Dr. Varun Thakur sir for his inputs and Dr. Rohit sir for one of his cases that he presented to me. Thank you, sir. Thank you, everyone.
Thank you, Dr. Apar, for an excellent presentation. And I thank all the young presenters for giving such a confident and inspiring presentation. And now I invite Dr. Sunil Mehta sir, Dr. Alok Vashne sir, and Dr. Nitin Gupta to lead the discussion.
Hello, good evening, everyone. And I think this was a wonderful session, and all the faculties have demonstrated in a wonderful way with the most practical thing. I mean, they have demonstrated the science, how to diagnose the things like isolated cleft palate, and Apar's talk was excellent. Beyond that, Shruti, Dr. Avantika, uh, uh, Dr. Aparna, Dr. Ashish, everyone has done a justice to their topic, and I think we are open to discussion about the questions if any we have.
All right, but first let's have comments from our mentors. Do we have Mohit Shah sir? Mohit Shah sir, how did the young guns perform today?
Perfectly as expected. Thank you so much, all the young participants. You did a wonderful job. Very crisp images, very crisp. Your talk was fantastic the way you delivered it. I'm extremely satisfied with what you've achieved. Thank you so much, and all the best for your future endeavors. Wonderfully done.
Thank you, sir.
Can I invite Dr. Khurana sir for his comments, our mentor emeritus, the inspiration behind all these webinars and educational activities?
Thank you, Alok. This is actually mutual inspiration. I get inspired by what I see on Young Guns and all the other guns that we've now seen recently. It's absolutely fantastic, the level of imaging that we've produced in India. It is now acknowledged as the best imaging in the world. Everybody pays attention to what we produce, and I'm so glad that Society of Fetal Medicine and wonderful young people like the ones who presented today do such a good job. There is one comment I'd like to make, and that is that we know that all of these finally get transcripted to our SFM YouTube channel. And if we have even one single slide which has a patient name on it, then unfortunately we have to either delete that or try and cover it. Now, it's impossible on a recorded video to cover it, so please make sure that all presenters have to anonymize all the images that they show. Otherwise, the entire presentation for the evening gets cancelled. So that's something that we really have to be careful about. Otherwise, as usual, extremely satisfying, extremely good images, very well explained, and the prognostication in particular seems to be really nice. There's also one piece of good news. Apar mentioned how we seem to lose so many cases to a complete follow-up because of the expenses on genetic testing. And I want to point out that one of our trade partners will now do free genetic testing for all patients who need genetic testing but are below the poverty line, which means they have a yellow card. And the yellow card is issued by the state health organizations. And if the patient has a yellow card, then they will get complete genetic investigation free of cost, irrespective of what it is. So that's the good news. But congratulations again, fabulous program, excellent presentations.
Thank you, sir, for your kind words. And of course, the young presenters, they need to be careful about hiding the patient name. So let's move ahead with the questions. We have a lot of accolades but very few questions. Let's address them. First is a question for Dr. Uh, Ashish. Ashish, you showed a case of increased intracranial translucency that turned out to be Dandy-Walker malformation later on in the second trimester. So when do you call it as a dilated intracranial translucency?
So as with the NT scan, along with the gestation age, we have all the checklist which is there within the fifth and 95th centile, which is there. For IT, unfortunately, it is not there, but we usually take it as 1.5 to 2.5 mm is the measurement which has been there. And what we see in this one is if the IT is obliterated or not seen completely, then we are suspecting as a case of a spina bifida which has been there. And if it is a little bit dilated, which IT is a little bit dilated, then we suspect a posterior fossa malformation, maybe a Blake pouch, maybe a Dandy-Walker malformation, maybe a Vermin hyperplasia. So we need to follow it. We just can suspect it. The is if you want a fixed date or fixed measurement, it's around 1.5 to 2.5 mm is the limit which is there.
Rana sir, would you like to add to it?
Yeah, you see, we did publish this in 2012 in the White Journal, and so you can get your data from there. The median IT increased from 1.48 at 45 millimeters and went up to 2.56 millimeters at 84, which is the same 1.5 to 2.5. But we did produce the fifth centile and the 95th. At that time, we didn't realize that the 95th would become so important. And now it has, but it's published data sitting there for you. It was 1,000 cases at that time, and then we went on to expand that to another 5,000 cases. So you do have Indian data in the White Journal of 2012.
Nitin, do you have any trick to getting the
No, as Saraj mentioned, I think, I mean, of course, the visual, the eyes, how we look it, but yeah, it has more importance when we see it is obliterated. So we shall pay more attention when it is obliterated. Of course, if it is looking prominent to your eyes, then better to keep them in a close follow up.
True. And I think it is always nice that you look at the fourth ventricular choroid plexus when you see an increased IT, because if you are not seeing the fourth ventricular choroid plexus, which means it has moved away from the midline, those are the cases that will turn out to be dysplasia or Dandy-Walker malformation. If you are able to see the fourth ventricular choroid plexus, even with a dilated IT, more likely it's going to turn out to be either normal or a Blake's boxes. So, but follow-up is very, very important in these cases. So let's move on to the next question. That is on the question was, is interrupted aortic arch related to cardiomyopathy in some way? Dr. Avantika, this question is for you.
Sir, as such, there is no primary association between interrupted aortic arch and cardiomyopathy. But if the cardiomyopathy is associated, there has to be some other cause for it, either genetic or metabolic or a syndromic association. But there is no direct association between these two.
Sir, your comment on this, you have any idea what can be causing the cardiomyopathy in these cases?
Well, first of all, we have to identify truly whether it is a cardiomyopathy or is it just related to just local dilatations or local hypertrophies as a consequence of minor flow disturbances. And when it becomes global to a particular area, then global to a particular chamber, then we would label it as a cardiomyopathy. I guess the one that's being referred to is a generalized cardiomyopathy, and that is not connected. Unless we have an etiologically similar thing, which is probably a very early CMV infection.
Yeah, so in her case, actually, it was a case with bilateral renal agenesis, and
yes,
in bilateral renal agenesis, that can be associated with dilated or even hypertrophic cardiomyopathy, some thickening of the myocardium can be seen in few cases.
Yeah.
So let's move on. And Dr. Himangani Thakkar has kindly given the answer that it is a bilateral renal agenesis which was responsible for hypertrophic cardiomyopathy in our case. So we are grateful to her. Then we have the question for Dr. Aparna. If there is right atrial isomerism, should we counsel towards continuation or should we counsel towards the termination of pregnancy?
I think, in my opinion, our job is not really to counsel toward termination or continuation. I think we just need to explain to the patient what kind of a postnatal life they can expect for their baby. And then after that, also, we need to explain to them that there might be chances of a recurrence if the genetic tests come out positive. But after that, I think it's the patient's decision to make whether to continue or terminate.
So probably the gist of question is they want to ask the prognosis. How do we explain a good
Yeah.
prognosis or bad prognosis?
So the prognosis, as I told in my talk, prognosis can be bad for these babies, especially if the TAPVC is obstructed or there is pulmonary stenosis. But now with the modern surgeries and the kind of care that we have, the survival rate has increased up to 86% for these cases. So we can explain that to the patient.
Yes, she showed in one of the slides that if it is a univentricular heart, then it's a lot of problems and
multi-stage operations.
Yes, so rest of the things can be managed, but by and large, because the abnormalities are very complex in cases of right atrial isomerism, it is a bit challenging. How would you counsel Khurana sir in such cases?
I really leave it very open. Now, I have seen patients who have very precious pregnancies, especially IVF, older mothers who've had their own gametes resulting in pregnancies, who would stick onto a pregnancy irrespective of the prognosis and take that sort of a chance, even if the duration of longevity is limited. So it's a very difficult question. You have to take other features into consideration regarding so-called precious pregnancy and then take a decision. We know that the prognosis is poor. We know that there are quality of life challenges, but patients would still opt for that in spite of everything.
Charu ma'am, how do you manage in your institution such pregnancies?
So we generally counsel them that multiple surgeries might be needed, and then if they are willing, then they generally go for continuation. Otherwise, the poor people, they generally opt for termination.
I think the parents, they know very well the challenges they are going to face later on, and they decide whatever is, suitable for their circumstances. Then we have another question, and this is for Dr. Apar Mathur. So, Apar, you have a few questions. One is cleft alveolus means that there is a cleft of the primary palate?
No, sir. The alveolus and the palate are quite different. So generally, what at least in the cases that I have read, not the literature that I have read, normally a cleft lip is almost always associated with a little bit, either it's just isolated or there has to be some protrusion into the alveolus, but alveolus is just the gum part. It's posterior to the alveolus where the palate actually starts, so it's different. It's just a cleft lip can have an alveolus defect, but by having an alveolus defect, we cannot diagnose the palate. For that, you have to see the maxillary arch and the dip in the maxillary arch. If there is a defect in the maxillary arch from the axial view, or if they're in the midline sag view, if you see the defect in the maxillary line, only then we diagnose cleft palate as well.
I think if we go back to the embryology, then we can very well make out what is the primary palate. And
should I share my presentation all over again, sir?
Yes, I think if you can show the diagram, and then that will be clearer.
Yes, sir. Yes. So this part. So that's the upper. That's the upper lip, the red line. We can see the line diagram. So the pink part here that's the alveolus. Here on the line diagram, this part that's the alveolus. So that's the gum, the gingival part. And posterior to that, that's where the palate begins. And such defects can only be diagnosed when we go down from the alveolus. This is where the palate begins, and to diagnose this, you need to have the defect in the maxillary line, and you need to see the coronal view to see go to the retronasal triangle and see the defect in the base of the retronasal triangle. That's where we start diagnosing the cleft palate.
So basically, the cleft, it starts either anterior or it can start posteriorly. And the anterior clefts, they can stop either at the lip itself, or it may involve the alveolus, or it may extend into the primary palate. Khurana sir, your comments on this?
So, we have many classifications of cleft lip and palate. And really, what we have to start doing is to be on the same page as the person who's finally going to treat these cases. So, when the plastic surgeon or the pediatric surgeon is going to treat these cases, and usually these days it's a maxillofacial surgeon, then we have to speak the same language as they do. And they definitely classify these as four different sections, which means they give a lot of importance to the alveolus because its involvement or not involvement along with the palate can give quite a different prognosis. And therefore, we have to follow what the clinicians say rather than just absolutely pure embryology. So this diagram that we are now seeing currently on the screen is really the most practical out of the whole lot, because this kind of a line diagram is truly speaking what the surgeons understand. If this is what the surgeons understand, this is the kind of diagram that we must add on to our reports rather than all our exotic images. They're of use for the person who can understand those. And most surgeons don't have the patience to go through these things.
Very true, sir. I think Kanohan's diagram is what is used for this.
That is right.
Yes, sir.
Yes.
Yes.
Yeah.
So that is very easy, and it is based on the embryological development also.
Yeah.
So can be followed very easily. And then there's one more question for you, Apar. It is, what are the clues for isolated cleft palate? So that seems to be always a challenge to identify the isolated cleft of the palate.
The only clue that I have ever heard of or seen of is that you have to go back, try to look at the visual, the uvula. If there is absent visuala, only then we start suspecting only the isolated cleft palate. But honestly speaking, and realistically speaking, we never try to visualize the uvula unless we start seeing that defect in the midline and the face on the face. So either we make it a habit or make it a second nature to see the uvula in every case. As Adi sir used to say it, that it takes 10 more seconds to go and visualize the uvula. But I said this are 10 seconds for you, maybe about 5 to 10 minutes for all of us. So it's very practically impossible to go and visualize the uvula in every case. But that's the only indication that I had.
Yeah. So Nitin, your comments on this, do you visualize the palate in your cases? Nitin, are you there?
Yeah. So what I believe that we can at least have a look at that equal to sign. That's very easy to obtain. Equal to sign is not that difficult. And if you suspect something, then usually what I try to do, I try to do that polyline thing by the Omni view, and we can get a sedge of nice sedge. That is one way one can attempt. Though it's not 100% sensitive, but yes, this is one of the way.
So Ashish Panchal has already commented, and this was a very nice webinar in our Next Gen Expert series given by Dr. Varun Thakur, and in which he demonstrated the posterior palatal line. Posterior palatal line. So if you focus on the posterior palatal line, and if it is appearing intact, it rules out the cleft of the primary palate, and if it can show various types of defect. And I think this is not usually incorporated in our checklist that we use for a mid-trimester anomaly scan, but more and more people, they are incorporating this as well. So our detection rates, they are going to be improving on this. Sir, your comments, Khurana sir, on this isolated cleft of the palate?
Yes, first of all, that it's not part of protocol.
Yes.
And that is important because you can't be really diagnosing these also, although they do seem to be of consequence. And every one of us, once every 2 or 3 years, is accused of missing one. The fact remains that it's not really so significant in missing one. And the effort to be made in getting that exact position without overlapping bony parts and bony shadows is not the easiest during the course of a routine scan, which is why we've never really included this. If there is a history of drug intake, if there's a family history or any other findings, yes, we will always look for these. Otherwise, from a general point of view, when people hear more and more of programs like ours, they're inspired to actually go to court and say, why did you miss this? And that is why we really have to be truly careful in proving how much we can see. So it's important to always consistently mention that this is not part of routine protocol. It's part of an
That
extended protocol in a particular clinical situation.
perfectly well said, sir. So, though, yeah, of course, we can look at whatever structures that we want to, but of course, there are going to be limitations, and it's not that in every case we'll be able to look at those structures. So,
Should I stop share, sir?
yes, please. And another question, this is by Dr. Manish Trivedi. For in arthrogryposis, the diagnosis can be done around 13 weeks. Should we counsel for continuation or termination? I think there are two parts of it for this. Can we diagnose every case of arthrogryposis at 13 weeks? And then if we do that, should we counsel to continue or terminate? Shruti, this is for you.
So, 13 weeks diagnosis, I won't say it is not possible if we are actually focusing on the lib movements, but not in all cases. Sometimes it actually develops later. Maybe in mid trimesters, we'll be able to find it, and we may miss in first trimester. So, it is not a good idea to always say that it should have been diagnosed in first trimester. It's not always possible. So, but yes, if we have diagnosed it in first trimester, now to make a call for termination or not, obviously the parents would be deciding it, but we have to know the etiology, why it is like why arthrogryposis is being there, because it is not the disease in itself. No, it is just a symptom which the baby is showing. So it will largely depend on the etiology, because as we saw, the arthrogryposis, it's a non-progressive condition more commonly. So if it's a precious pregnancy, again elderly primies, and your situation is like that, the pregnancy they want very much to continue the pregnancy, definitely they should be supported, because if the joint contractures are managed well, the babies have a good lifespan. There is no intellectual issues. There are even I mean we can see a lot of videos of such kids all around who are promoting this, that how by managing their contractures, they are able to go through and live a normal life in routine. So it's not so that termination is indicated in itself, but definitely we need to know the etiology. By and far, without knowing the cause of arthrogryposis, we cannot make that call. A direct call is not possible.
So, truly said that some of these cases they can be managed very, very well. Your experience, this arthrogryposis always seems to be a big challenge for us, Khurana sir. Your experience with such cases.
Yeah, so we know that the vast majority of arthrogryposis are late in onset and that the vast majority are progressive. That arthrogryposis is not a diagnosis by itself, but a morphological label. And because it's a morphological label, we need to get to know and exclude, as so beautifully highlighted by Shruti, we need to get to know the diagnosis, and then we'll have a much better idea of the prognosis. It's not a simple, straightforward feature. If this is present, this is not, and so on. A lot of fetuses who are diagnosed even at the 22-week scan will show a huge amount of polyamnios by the time they're 26 to 28 weeks, because the movements are so erratic. And therefore, it's not a simple diagnosis at all. It's very rarely, in fact, diagnosed at 13 weeks. And those are invariably lethal or result in such a severe polyamnios that they result in spontaneous miscarriages or preterm birth. So they just look after themselves. It's the subtle ones that really go on to becoming more progressive beyond 28 weeks that are difficult to handle, because in those situations, even a medical board does not give permission to terminate these pregnancies because of the variable prognosis. Then, of course, one is stuck with what we have. I normally do a late genetic evaluation, even if I diagnose these at 28 to 32 weeks, because then you know that there is no point trying to treat the polyamnios and preventing preterm birth. You just let them go, and that's the best way to handle it.
The etiology is very, very heterogeneous in such
Very
cases.
heterogeneous, yes.
And without genetics, it's very difficult to prognosticate such cases.
Yes, and an MRI as well, because there's a lot of neuro background in a lot of these, and that needs to be assessed very carefully after 26 weeks of gestation.
Very true. And it's not that always the major joints are going to be involved. Sometimes it can be simply fingers, very subtle arthrogryposis can also be there.
Yes, yes.
Okay, thank you all for your inputs. And then we have two more questions. So one is again for Apar, if maxillary arch is involved, then is it only the alveolus cleft and not palate? Is that true?
Uh, if the maxillary arch is involved, we have to go and look anterior and posterior to what is the actual depth of it. Is it actually just the maxillary arch? Most likely, the maxillary arch will be involved with the cleft. More often than not, it is involved with the cleft lip. So the alveolus comes in between. So we see the defect all throughout. However, very rarely, at least I have never seen one that the maxillary arch is involved and the alveolus isn't, and there is no cleft lip or cleft palate associated with it. Very rarely that happens. But again, if you see a defect in the maxillary arch, more often than not, there will be an alveolus defect present with it.
All right. So rest of it we have already covered, and people are again full of appreciation of how well the young presenters have presented. The presentations were very, very lucid and crisp. They covered the topics very well, and the imaging was excellent. Sunil Mehta, sir, final comments from you before we wrap this up.
Yes, Alok sir, the presentations were really very, very good. And our presenters, they did a lot of hard work. And I must acknowledge that your guidance for almost last 1 month in getting them preparing all these presentations and fine tuning them and ensuring that all our presenters they finish their presentations in time. That was very valuable for all of them. And I'm very happy that in Rajasthan also the younger generation, they are doing very fabulous work. And best of luck to all of them. Thank you.
Thank you so much, sir. So shall we call it a day? I think the presenters, they did very, very nicely. Mohit, sir, would you
Yes.
like to say closing remarks?
No, I am very happy. As Mehta sir said, I'm very glad to see Rajasthan also doing excellent work, because there was a time when we were not having too many faculties from Rajasthan. But if you look at the presentations today, I'm very glad that the future of Rajasthan is in great hands. Wonderfully presented today. Congratulations and wish you all the best again.
All of the presenters, they were absolutely fluid in their presentations, and confidence level was so high. And because
Yes,
they have worked these cases themselves, so
right.
that is why there was so much confidence. Uh, Thank you, Dr. Charu, madam, for hosting the program, and thank you for all of your inputs.
Thank you,
Prana,
sir.
sir, thank you so much for being there and joining every program. You inspire all of us. And thank you for the team of SFM Rajasthan, Nitin, Charu ma'am, and Sunil Mehta, sir. Mohit Shah, sir, goodbye. I think, are you driving? You're not driving, hopefully.
Yeah, yeah, yeah.
All right.
Yeah.
Thank you for joining the
Bye.
program and for your inputs.
Thank you.
And Conferences International
Thank you.
team, thank you for hosting the program. So let's call it a night. Good night, everyone. Thanks for all the
Right, sir.
delegates
Thank
Bye-bye.
you, sir.
who have
Thank you.
joined
Thank you
today.
all.
Bye, sir. Good night. Good night, everyone. Bye.
And
Thank
this
Good
you.
night,
will
sir.
be
Bye.
hosted on our YouTube channel, SFM YouTube channel, in due course of time.
Thank you, sir.
Good night. Good night.
Thank you.